Okay, so good afternoon, everyone. I'm going to introduce our next speaker. Dr. Chen is an associate professor of research at the RJMS Department of Family Medicine at Rutgers University, and she will be presenting her research on violence, outreach, intervention, and community education, voice, reducing interpersonal gun violence in New Jersey cities. Dr. Chen, you may begin.
Hi, everyone. My name is Hsin Chen. I'm the principal investigator of this program, voice program. Dr. Sahul Navni, he is the co-principal investigator, and Dr. Bani is our consultant for this program. So just give you some background of the project. Gun violence is a major public health concern in the U.S. For every death related to gun violence, there are 2 more victims sustain non-fatal gun injuries. Guns are the leading method of suicide and homicide, and they account for half of all suicide deaths and about 70% of all homicide deaths. There are several risk factors for gun violence, including depression, substance use, intimate partner violence, and gun violence exposure, and others. Depression and mental illnesses can be a strong factor in suicide, and suicide accounts for the majority of firearm deaths. Alcohol and substance use and intimate partner violence also led to firearm suicides and homicides. Also, when a person becomes a subject of gun violence, the risk of someone in his or her social network becoming involved with gun violence increases. So here you can see that there are 2 main types of gun violence intervention programs. I just give you a comparison here. So one type is we called hospital-based violence intervention programs, and one type is the community-based intervention programs. So you can see the focus of the 2 programs are a little bit different. But we are thinking that actually, according to what we have done in our research in our university hospital, the trauma center, we found that about 40% of patients who died due to injuries sustained by gun violence had past outpatient medical visits in our university hospital. So for survivors of gun violence, this percentage probably was much higher. So our voice program aims to combine the 2 concepts of hospital-based community programs to offer educational sessions in both clinical and community settings. So just give you a little history of our program here. We actually did not just start last November. We actually did our preliminary program in the past 2 years. So so in 2020, me and my research team worked on a project which laid the foundation for this year. We identified risk factors for gun violence, conducted literature review, created a PowerPoint, and pilot tested. In 2021, you can see on the right-hand side, our research team held daily meetings, engaged community stakeholders to determine how our project could be most meaningful for the community groups, and developed animated educational videos, well, actually based on the community feedback, which were user-friendly, and create pre- and post surveys to evaluate the success. And then we pilot tested with peers and newer community members. So now we talk about our current program. The aims of our current program are to promote gun violence prevention and intervention through a collaboration between community workers and healthcare providers, as well as tailor and deliver the violence prevention curriculum for community and hospital partners. Our goal are to improve the knowledge, awareness, safety, and access to care for gun violence. We also aim to have a program that participants are satisfied with and would recommend to family and friends. So here, before I mention about the community organizations, let me introduce a little bit our team members. So our program team members include Rutgers, New Jersey Medical School faculty and students from the community engaged service learning program, Rutgers biomedical and health sciences students, and voice coordinators. We facilitated virtual, hybrid, and in-person sessions in New Jersey cities. Several team members are bilingual and can provide translation during the sessions. We are also making Spanish videos and pre and post surveys. So according to specific M1, we want to engage a learning collaborative of community workers and healthcare providers to promote gun violence prevention and intervention. We sent invitation letters to community organizations through emails and conducted online and in-person program information sessions for the community organizations that were interested in participation. We met with them and conduct the program based on their needs. Each organization chose the topics they are interested in and decided how often they want to meet. So here are the community organizations that we have been closely working with. We did weekly to monthly sessions or scheduled event sessions for each organization. Each session, learning collaborative session, took about 30 minutes or 2 hours, depending on each community organization's schedule. The program team did presentation on 1 to 2 topics each time, followed by discussion with community workers and organization staff. We provided gift cards for participants. Here are the 9 topics. Here are the 9 topics we cover during the sessions. So they are gun violence prevention introduction, effects of gun violence, gun safety planning and crisis management, gun violence intervention programs, gangs and gun violence exposure, role of depression in gun violence, substance abuse and drug use, intimate partner violence. COVID-19 related issues, this topic was specifically requested by the community organizations. They asked us to present this topic, so we added one at the end. So our specific M2 was tailor and deliver the validated violence prevention curriculum for community and hospital partners. We work closely with the community organizations to deliver the program to their clients. We modify the session content according to the literacy level of the clients and use the format based on the preference of the clients. Some educational sessions are virtual, some are hybrid, and some are in person. For example, we go to Broadway House in person bi-weekly. The program team members distributed paper copies of surveys and presented the videos in their cafeteria. We did online in-person weekly sessions for local domestic violence shelter using Zoom polls to do the surveys and video presentation. We go to another 2 homeless shelters to conduct individual sessions. Usually on weekends, we set tables and used iPads to conduct surveys and video presentations. We also attended community public events to recruit participants. We set up tables at the events, and participants use their phone or iPads provided by us to fill out online surveys and watch the videos. For hospital and school-based outreach programs, we collaborated with clinics and their outreach programs. Similar to the sessions in community organizations, there were one-on-one outreach and scheduled group sessions in clinical settings and school events. So here are the links to the pre-survey, the presentation, the videos, and the post-survey. I put 4 sessions in the slide, and then the next one, the other 4 slides, 4 sessions. And as I mentioned, the COVID-19 session was requested by the community organizations. Each online pre-survey and post-survey takes about 2 minutes to complete. Each video takes about only 5 minutes to watch. So now I want to present to you the results. So far, we are actually still conducting the sessions. So there are this table summarizes the number of participants in each topic. For each session, the participants did both pre and post surveys. As organizations and participants can choose the topics that they are interested in. So you can see that some sessions have more participants and some sessions have fewer participants. Participants join at least 1 session. Some of them, they did 9 sessions altogether. As the surveys are anonymous, we did not track all names over time, but we estimated that about 1/3 of participants, they joined longitudinally. So now I'm going to present by topic, because I think that you will be able to see the demographics and the pre-survey questions we ask at each session. So on this slide, on the top, you can see the demographics. So almost half of our participants were between ages 18 and 44, and more than 50% of the participants were male. Most participants were minority groups, and about 75% are from Greater Newark area. As you will see in later slides, the demographics of the participants for each topic were similar. So I'm not going to repeat the demographic information, but I will present the questions that we ask in the pre-survey. So you can see that the chart at the bottom shows that more than half of the participants had heard gunshots in their community environment in the past 6 months. And in this slide, for the session on effects of gun violence, about 80% of participants were likely or felt okay with help seeking, as shown here, 80% to 83%. For the gun safety session, more than 3/4 of participants said that they were likely or felt okay with help seeking. So when we presented intervention programs to participants, about 3/4 of the participants stated that they had seen someone have significant interactions with police, and more than 60% had seen someone being threatened with serious physical harm. Almost 40% had seen someone else being shot with a gun. In regard to gang violence, almost 1/5 of participants had seen someone get chased by gangs or older kids. More than 10% had heard shots in their community environment in the past 6 months. 5% had seen a gun pulled on someone in the past 6 months. In regard to substance use, more than 60% participants know someone who used drugs recreationally and have had a friend who wanted to cut down on drinking or drug use. In the depression and gun violence session, more than 40% of participants know someone who experienced a core symptom of depression in the past 2 weeks. For intimate partner violence, more than 30% of participants know someone who physically hurts, insults, talks down to, threatens at, screams at, or curses at their partner. The charts show participant satisfaction and the degree of to which they would recommend the program to others. So you can see that almost all participants reported overall satisfaction with the presentation and would recommend the content, the program to others. So here we show you the knowledge gain. So you can see that knowledge gain ranged from 88% to 98%. So out of 100 points. So overall, when we look at the data from the 8 videos and pre and post survey, we feel that in the community, the prevalence of gun violence, exposure to gun violence, gang violence, substance abuse, depression, and intimate partner violence, the prevalences are pretty high among the participants. But on the other hand, we also see that there is an urgency to have more prevention and intervention programs. You can see that 98% were satisfied with the presentation, and 98% would recommend the presentation or the videos to others. We also showed high post-intervention knowledge score. So the overall score is 93 out of 100. And as I stated in the previous slides, about 80% feel comfortable reaching out to resources. So here are our conclusions. Most participants were satisfied with the program and would recommend the program to others. And most agreed or strongly agreed to reach out to resources if needed. And we believe that the VOICE program is effective in conveying information on gun violence and its risk factors. It can be incorporated into early screening and intervention programs in clinical settings and communities. This slide, I want to show it to everyone. We still have about 1 month to conduct a study. So we want to invite everyone to participate in the VOICE program. We are still recruiting community organizations and individual participants. So we will provide gift cards to the participants by the end of June 30th. So if you are interested, please contact me. My email address is here, chenpi@njms.rutgers.edu. Acknowledgments. This work was supported in part with funding provided by the New Jersey Gun Violence Research Center at Rutgers University and Rutgers New Jersey Medical School Community Engaged Service Learning Program. And here are the references. That's it. Any questions? Let me go back to the
Thank you, Dr. Chen. Yeah, just end your presentation. You can see the questions. We do have one
okay.
from Claire King. She asks, could you please restate from which courses or disciplines did the service learning students who worked with and presented to participants come from? Were they sociology students, family medicine students? Thank you.
Okay, so in New Jersey Medical School, we have this community engaged service learning program. Actually, all the medical students are required to provide community services. So one of the programs, the CISO, we call it CISO programs. The CISO programs is Domestic Violence Intervention Program. And I'm also involved in that program. So through the students signing up, we have about 30 medical students each year. So they voluntarily go out to conduct the sessions. But as you know that during the past 2 years, because of the pandemic, sometimes because we follow the outreach program rules from Rutgers, so we did stop one month in January because of the pandemic. But I think that it's really nice that we have this, Zoom meetings and different virtual meetings available. So we were still available, able to conduct the program during the pandemic.
I have another question from Taylor. Did you find any difference in people's responses based on the way they did treatment, like telehealth, in person, or hybrid?
This is a very interesting question because I think that for some of you, so let me talk about the original purpose of the study. Originally, we are thinking that because of the pandemic, so we will do all online sessions because that is just more convenient and then more feasible for people. But when we started this current program last November, a lot of participants and also community organizations, I can feel that they are actually tired of Zoom meetings and online sessions, including our medical students. So we actually ask them. We respect their choices. So if they want to do in-person sessions, then we do in-person sessions. So I personally think that when we do in-person sessions, actually, obviously it's more interactive. Like for example, for Broadway House, we go there, every other week. We see people, and when we do the online sessions, unfortunately, sometimes there are technical issues. We think that it's easy for us to access to Zoom, to Teams, to other online apps. But for community members and also sometimes community organizations, I think it's really hard for them to access, and even the QR codes surveys, sometimes it's not easy to conduct. So I think that this is my personal opinion that community members seem to be more they probably like the in-person sessions more. We actually also go to parks, go to public events, including Rutgers Day. Beautiful weather outside, and we just invited people to sit down, and they can use their phone, their device to just watch the video and do the pre and post surveys. Very convenient.
Thank you, Dr. Chen. So I don't see any more questions, but please feel free to reach out to Dr. Chen. I've provided her email on the comments box. I can give you guys back 5 more minutes before the next session. You can click on the sessions tab again on the left side and click on any session that starts with the 2. So breakout session 2A, 2B, or 2C. Again, thank you, Dr. Chen, and we look forward to your project's completion.
Thank you. And last sentence, I put my email address there. I do invite everyone to participate in the program. Please contact me through email. Thank you.
Thank you.